Hi, everyone. This is Catherine Mickelson in Boston. Thank you so much for joining us this evening. We are delighted to have with us Dr. Gary Raskob and Barbara Krolak. They are both from World Thrombosis Day. Dr. Raskob is chair of the steering committee for World Thrombosis Day, and Barbara is on the staff and she handles marketing and membership for them. World Thrombosis Day, for those of you that don't know, is a huge day in the thrombosis community, just really raising awareness and doing outreach. I'm sure many of you can appreciate you have family members and friends that don't even know what blood clots are, so we're really trying to change that. So we are honored to have Dr. Raskob and Barbara with us, and with that, I will go ahead and turn it over to them.
Thank you very much, Catherine. And let us say on behalf of the campaign and the International Society of Thrombosis and Hemostasis, we want to thank the North American Thrombosis Forum for their great partnership in this effort, for the opportunity to be with you this evening, and for all that you do throughout the year. World Thrombosis Day is really the culmination of ongoing year-long activities, and we have many, many partners like the North American Thrombosis Forum who are working all over the world, more than 1,500 partners now. But I want to give a shout out and recognize your efforts because it's so important on a continuous basis. So World Thrombosis Day is a global movement to place a spotlight on thrombosis as a urgent and growing health problem. And you can see some of the many activities in this slide from partners all over the world. The mission is to increase global awareness of thrombosis, its causes, the risk factors, signs and symptoms, and evidence-based prevention and treatment. Now, ultimately, this effort should help reduce death and disability caused by thrombosis, and we are certainly in line with what the World Health Organization is doing and the World Health Assembly in terms of reducing non-communicable disease, and thrombosis is a key contributor to that throughout the world, and I'll say a bit more about that in a moment. So our objectives are to highlight the burden of disease from thrombosis, increase public awareness, empower individuals to be knowledgeable in their engagement with healthcare providers about thrombosis, their risk and prevention, to galvanize organizations to work together and to advocate for systems of care, and also to policymakers to prevent, diagnosis, and treat both venous thromboembolism and arterial thromboembolism, and atrial fibrillation is a key one that we're working on there. So if we go to the global burden of disease from thrombosis, I think many people, even in the thrombosis community, will be surprised by this fact that thrombosis as the underlying cause of heart attacks, acute coronary syndrome, most strokes in developing countries, and venous thromboembolism, deep vein thrombosis, and pulmonary embolism is responsible for 1 in 4 deaths globally. Wow. Thrombosis causes 1 in 4 deaths on this planet. And you can see there from the Global Burden of Disease study in this slide, which is a regular project that is conducted in collaboration with the World Health Organization and World Bank, that in 2015, ischemic heart disease caused almost 9 million deaths across the world. Cerebrovascular disease, 6.3 of which about half of those were thromboembolic stroke, because in developing countries, hypertension is very common and contributes to a high proportion of bleeding strokes. But in developed countries, thrombotic strokes are the dominant type of stroke. And then venous thromboembolism, which was not specifically assessed in the Global Burden of Disease study, something we're trying to change so we get more accurate data around the world. But we know from some other World Health Organization efforts that, and some research both in the United States and Europe, that there are several million deaths from venous thromboembolism throughout the world. So World Thrombosis Day being launched when we did 5 years ago, there was a World Heart Day and a World Stroke Day in existence. And so we decided to focus in on venous thromboembolism because we think that this was a very much underappreciated condition. October 13th is the actual World Thrombosis Day, and I put this slide in because that is the birthday of Rudolf Virchow. He is the pathologist who coined the term thrombosis and embolism and worked out the underlying pathology of venous thrombosis, that is the contributions of 3 factors: slow flow in the veins or venous stasis, activation of the clotting system or hypercoagulability, and damage to the blood vessel wall. And if you have 2 of those 3, that's enough to stimulate a formation of thrombosis. But thrombosis is an important public health problem, and Virchow was very active in broad public health as well. And he said that physicians are the natural attorneys of the poor, and that they should solve all the social problems. So something we should think about, but certainly we are honored to recognize his contribution, and that's why we have World Thrombosis Day on October 13th. As I say, it's a culmination really of year-long activity. So when we look at venous thromboembolism specifically, I can say now we've just completed a study in Oklahoma where we've surveyed the entire county for all cases of venous thromboembolism over a 2-year period. And we can say that 3 people per 1,000 general population, age adjusted, will develop a deep vein thrombosis or pulmonary embolism. 3 per 1,000. But that's, of course, age adjusted. When you get into the 70s or the 80s, the incidence rate goes up to 7, 8, or higher per 1,000 people. So it's very common. The CDC documented that in 2007 to 2009, there were more than 500,000 hospitalizations each year with venous thromboembolism. And we estimate about 900,000 people develop this condition each year in the United States, with 100,000 to 300,000 deaths from venous thromboembolism. Europe, based on the study quoted here, suggested over 500,000 VTE-related deaths back in 2004, so that's likely to be quite a bit higher now. And the World Health Organization documented in a study of many countries across the spectrum of low, middle, and high-income countries that hospital-associated venous thromboembolism is a leading cause of death and disability associated with a hospital stay. And they were very surprised even to see this, because this is more than contributed to by nosocomial or pneumonia, or by catheter-related bloodstream infections in hospital, or by adverse drug events, or any other of the multiple adverse events associated with the hospitalization that they surveyed. And so VTE associated with a hospital stay worldwide is a big contributor to death and disability, known as the DALI. Our colleagues at the CDC have documented that the healthcare costs directly attributable to the venous thromboembolism often complicates other medical conditions or hospital stays, so patients already are using the healthcare system to a certain extent. But the first episode venous thromboembolism events in the United States add to our cost of healthcare $7 to $10 billion annually, just by the nature of developing these thrombosis. And we know that for patients with unprovoked venous thromboembolism, those who come without any identifiable risk factors, that the thrombosis is an important cause of work-related disability. Back at the start of our World Thrombosis Day campaign 5 years ago, we decided to undertake a survey of the general public about awareness of thrombosis. And you can see on this slide that across the country studied, and there are 9 countries studied there: United States, Canada, Argentina, United Kingdom, Germany, Netherlands, Thailand, Australia, and Japan. Across these countries studied, it was very consistent that awareness of deep vein thrombosis and pulmonary embolism was quite low at 50% or less. Awareness of high blood pressure, heart attack, stroke, breast cancer was quite a bit higher, up in the 85 to 90% level. We believe that's largely because there have been aggressive campaigns to educate the public about those conditions, for example, by the American Heart Association or the American Cancer Association with respect to breast cancer. And you all know this is Breast Cancer Awareness Month in October and many pink ribbons. But there hasn't been a campaign toward venous thromboembolism other than the work that people have been doing. And again, I really commend the effort that the North American Thrombosis Forum is doing, because patient engagement on this is so very important. So when we look at this, not only were people quite unaware of deep vein thrombosis and pulmonary embolism, they were also unaware that this is a preventable condition, and they did not know the risk factors. So we see here cancer, hospital, surgery, quite a low awareness that these items are risk factors for developing blood clots in your leg veins and your lungs. Therefore, we decided to really begin with a focus on hospital-associated venous thromboembolism, because about 45 to 60% of all cases have a history of being in the hospital within the previous 3 months. So it's a key point at which we can access patients for prevention. We have effective prevention for most patient groups, and VTE risk assessment is indicated for all patients who are admitted to hospital. We also know that the risk period often extends for 90 days after the hospital stay. Therefore, we are really trying to get the message out about the importance of doing a VTE risk assessment when patients are admitted to hospital. We have some good evidence that this is helpful from a health system. In the United Kingdom, the National Health System in England implemented in 2010 a requirement that all hospitals do a risk assessment for venous thromboembolism when the patient is admitted using a standardized tool. And if the hospital did not achieve a target of 90% or more of hospitalized patients being assessed by this, they were given a financial penalty. And then they evaluated this over the subsequent 2 years and found that the rates of fatal venous thromboembolism at 90 days were reduced by 15% if the target was achieved. That is, if 90% or more patients are risk assessed at admission, you will save lives and prevent deaths from pulmonary embolism. This applied to both surgical and non-surgical patients, such that almost 900 deaths were avoided in England during those 2 years shown on the slide. It would be reasonable to say that we would have a proportionate effect in the United States. Therefore, our steering committee made a call to action to say that we feel there's enough evidence in the literature on different approaches for risk assessment. There are validated risk assessment models. We know we're learning about the value of a blood test called the D-dimer. We have prophylactic approaches available that we really feel that all patients admitted to hospital should be assessed for their risk of VTE, and we're asking all health systems to support this. And of course, in the United States, CMS has come along with some guidance and recommendations, firm recommendations, requirements that this be done. So how can you get involved in World Thrombosis Day? And this is really crucial to the success. The grassroots efforts that our patients and our family members and our public partners are doing are really fundamental and critical to the effort of the campaign. There are several fun and free ways to participate in the day. Here you can add a World Thrombosis Day frame to your profile picture on social media. You can share survivor selfies on social media or at the website. Tell your family and friends and colleagues about this and get them to join. Register to, our webinar was this morning. I think we had a very good webinar, but it has been recorded and we can distribute that to people. And tomorrow we'll be having a Twitter chat at 10 a.m. Eastern Time, and we ask as many people to join that as possible and join the conversation. There are more than 9,000 awareness activities and events going on all through the spectrum, including dog walks, which I saw many dogs walking in Central Park this morning when I did my walk. Free health clinics, social media is just so crucial to this. Myself and Dr. Elaine Heilich from Boston did, I think, probably a couple dozen interviews together between us with the radio over the past couple days. So just trying to cover the gamut of these various activities, and if you can get involved in any of these, we encourage you to do that. We're having a hospital workshop here in New York tomorrow. Many others across the world are doing similar activities. Join us for the Twitter chat tomorrow. We're honored to have the guest moderator, Dr. Michael Gibson, from the Harvard Medical School and founder and editor-in-chief of Wikidoc. And Michael does just a great job on this. And many of you, if you're not following him on Twitter, I would recommend you do so. He does a great job and has a great reach and has been a great partner for us in helping to do this, along with our media co-host, Medscape Education, Everyday Health, which is an online health education website and magazine, and The Economist. So we're really proud and excited about the quality of these media partners in helping get the message out. But again, we encourage everyone to join this Twitter chat. Send in your questions. We try our best to not only do canned points, but to be responsive to the conversation and give answers. We're really excited that we've announced the first Thrombosis Ambassador of the Year award for this 5th year anniversary of World Thrombosis Day, Christine Ashimwe from Rwanda, who has done a remarkable job just as one individual being an ambassador in their community, region, country to motivate others within the thrombosis community about this condition, to educate others, raise awareness. And so we really feel that with these awards, we'll be recognizing individuals who do this. And we're really pleased that, again, I think this speaks to your group tonight, that we really appreciate that, for example, some of the health professionals like myself or our other clinical leaders, that's part of our day job to work on thrombosis. But the patient survivors, the patients and family who are getting engaged are doing this on their own time and voluntarily to really make a difference in this condition. And we're just so proud to recognize them. And we're really excited about this award going forward. So if you want to make a difference, maybe someone on this call might be the ambassador of the year next year. Finally, then, we're celebrating our 5th year. It's been a lot of work getting this up and going. We couldn't do it without the great work of all the partners. And again, we really, really appreciate all that you are doing every day. And it's just an honor to be with you tonight. And I thank you for that. And I'm happy to stop there and have conversation or questions with all of you about this important condition. Thank you very much.
Oh, thank you, Dr. Raskub. That was really wonderful. I mean, 9,000 activities. That's kind of unbelievable when you think about it. I mean, that's when you think back to even just a few years ago, I mean, nothing was being done to really raise awareness about thrombosis. So to be at this point is really remarkable. So you're to be congratulated for that. That's wonderful. So we did get a few questions in, and I do want to remind attendees that you can go ahead, you can raise your hand if you want just by clicking the little hand icon that should be right next to your name, or you can, if you're feeling shy, you can submit a question directly to me using the chat function or the question function. So we will start going through what we have received already. So one question we got is people associate flying with a risk for blood clots. Do you think airlines should provide more information on that? Or is it just not a large enough risk compared to surgery or hospitalization?
So thank you. So it is a risk. You may know some of the airlines are already doing this. If you read their magazine, you know, the dirty magazine that's in the pouch in front of you when you're on the plane that I don't usually look at, but if you pull it out of there and flip through, usually towards the back, you'll see a page there with some information. I know American Airlines has that. I think Delta has that too. And they have it there to give people just an awareness. I think probably more from their lawyers than any other reason. But long air travel, of course, can be a risk. But for most people, it's not a big risk. Really, those people for whom it's an issue are those with an underlying genetic predisposition or other minor risk factors, or if you've had a thrombosis in the past. So to summarize, what I would say are the recommendations for this are, if you have had a deep vein thrombosis or pulmonary embolism, or if you have a family history of that, or you know of people in your family who've had that, or if you have multiple risk factors, you might want to talk to your doctor about whether you should do something as preventative. And of course, we now have easy anticoagulants to use. So, but I would base that on a discussion with your doctor. For everyone else who's not had a thrombosis, just a good general practice is, you know, every say couple hours on a flight, in a car ride, whatever, get up, move around, stand up. You can also do exercises at your seat with dorsiflexion. That's, you know, flexing your foot back and forth to help promote calf muscle contraction and flow of blood. For the average person, you know, those kind of activities. But again, for our people on the call today, if you've had deep vein thrombosis or pulmonary embolism in the past and aren't currently on anticoagulant therapy, talk to your doctor about what you should do if you do go on a long plane flight.
Great, thank you. The next question is, how can you reach out to women specifically about the risk for PE and DVT when on birth control without seeming like you are quote unquote preaching to them?
Well, thank you. That's a terrific question. You know, I think that there are several things we need to do on this area. First of all, we have to recognize ultimately that to practice good evidence-based medicine, it includes patient preference. And so we have to listen, we have to educate our physicians, our young physicians coming up and so on, to be engaging, to listen to the women's preferences, to recognize sometimes they may not be the same as our own, but to respect that and to incorporate their preference into our decision making. I think the style we should use is one of providing clear factual information about the risks, but not predisposing, you know, or valuing one decision more over the other. And I think we should be balanced in the presentation. Pregnancy is also a risk for thrombosis. give good factual evidence-based information and respect patient preference in the decision-making process.
All right, terrific. Why do you think that Americans have fewer deaths due to VTE than in Europe? Is it due to our healthcare, prevention, or accessibility to certain medications?
So I'm not sure that we do, because we don't have, I think the study done in Europe was based on a larger population at the time than the population of the US at that time. So roughly at that time, probably the population of Europe incorporated into the study I showed was about 150 million people more than the United States. So I would say, I would guess from everything I see, that the incidence rates are fairly similar, and we probably have similar rates of death. If there is a little bit of an excess in Europe, I would think it's due to perhaps a little bit different distribution in age. As you saw, the incidence and risk of developing venous thromboembolism goes up significantly as you age, and there are, I think, a number of countries in Europe that are, I think, ahead of the US in the proportion of people who are in their 70s and 80s in the society. So if there is a little bit of excess, I would think it's mainly due to the age differences.
Okay, excellent. There are new drugs like Eliquis. Do you know of any future developments for people who have existing clots?
So the drugs like Eliquis, which we call the direct-acting oral anticoagulants, have been a big advance for things, because for many years, ever since up until these drugs, and I've been working on this area in research for 30 years, we had only one oral medication, and that was Warfarin. So we've made, I think, big strides with these new agents. And there are some other ones ongoing, and the most advanced area right now for anticoagulant of the future will be something that targets yet a different clotting factor in the sequence of clotting factors, and that's the clotting factor 11. And the hope is that we'll be able to improve even further on the safety of these anticoagulants by reducing bleeding, and factor 11 has a lot of rationale why, or inhibition of factor 11 has a lot of rationale why it might be a safer approach to anticoagulation. But we've really markedly improved safety with the use of drugs like Eliquis compared to Warfarin as well. So, but it's important, I think, for patients to know, and I appreciate this question, a lot of really rigorous, continuing, ongoing research to look for even better treatments.
Awesome. Now, treatment is one thing, but what about prevention? Why doesn't prevention, seem to kind of get the same attention that treatments do? It seems, we do a lot of educational programs for healthcare providers and for patients, and prevention is just never quite as hot a topic, it seems like. Why do you think that is?
So I think that's, first of all, I think that's broadly the case within our health efforts and within public health in the United States. Only 3% of total health spending in the United States is spent on preventive programs, so just as a general point. But I think in the case of venous thromboembolism, it's several reasons. One is, I think some people are not aware of the risks, although prevention in surgical patients now, most groups, is pretty well entrenched. I would say it's pretty routine at any, substantive place in the United States. If you're having hip or knee replacement, you're going to get prevention. If you're having other major surgeries, you're going to get prevention. I think that hospitalized medical patients, people with heart failure, respiratory conditions, pneumonia, other, infectious conditions. I think that there we need to continue to emphasize the importance. And I think it's because sometimes the bad events are not recognized or attributed to being thrombosis. We know very clearly that patients who die, and often it may be weeks after their hospital admission, and by a different physician sees, learns of it, it may be attributed to another cause like a heart attack or cancer. We don't get many autopsies these days, so and it doesn't occur in any one group that commonly that doctors in their own practice see it a lot, but overall it's very important. So these factors come together. We have to do a better job of emphasizing it. I think also our length of stay in hospital has been shortened quite a lot in recent years. So, in hospital, it's easy to give prevention. Out of hospital, not quite so easy.
Mm-hmm. Interesting. So it seems like there's still a lot of work to be done in the prevention area.
We want to keep emphasizing that. Yeah. Mm-hmm.
Yes. Great. So this is a bit more of a specific question, but is there any benefit to wearing compression stockings when sleeping for an existing DVT?
I think that's a good point. Probably not so much for sleeping. The whole potential value of compression stockings has been the subject of a debate for a number of years because there were clinical trials suggesting a benefit, then there were some that suggest not. And now more recently, there's just a recent study which suggests benefit. The key role for compression stockings is when you are standing for periods of time, because people with deep vein thrombosis may have damaged valves and blood therefore is pooling in the legs, after they're standing for long periods of time. When you're sleeping, you're horizontal and you're not pooling blood as much there. So, but if you don't mind them, they won't hurt you. And if you want to be extra aggressive on that and you don't mind it, I don't think it's a problem. I don't know specifically of any studies that have addressed that, but certainly, if you've had a DVT and you're using compression stockings and you're going to go to the mall shopping for a couple hours, or you're up on your feet for much of the day, that's where they really benefit. Or if you're sitting for a long time.
Okay. I don't know why someone would want to wear compression stockings longer than they have to. They seem very uncomfortable from what I've heard. But I guess you get a great benefit from it.
Well, some patients do complain about that, and we have to pay attention. And they can be hot in the summertime, and for women, they need to, I think we need to do a better job of getting some more fashionable compression stockings. Let me put it that way.
Yes. Are there plans for mandated VTE risk assessments tools in U.S. hospitals?
Yeah. So CMS, the Center for Medicare and Medicaid Services, has made some guidance recommendations on this. The payment models that are being reformed are, working to incentivize prevention of hospital readmissions, which would include venous thromboembolism, for example. So there is some good movement towards realigning for that. And we're working with various other stakeholders to just get people to understand that this is such a crucial activity. It's not expensive. It's pretty easy to do. And we're working to get hospital systems to also adopt this as a routine. And many of the big systems in the country have done that. For example, the Kaiser Permanente system in California, the Intermountain Health System in Utah, where we are going to be tomorrow, the Northwell Health System here in New York. And I would bet you've got something pretty significant within the partner system on this as well.
Yes, I think Sam and Greg Piazza, Sam Goldhaber, our president, and Greg Piazza years ago worked on something like this. And it was an uphill battle, but I think now it's, in place and, just part of the normal protocol.
And that's why I think the study from England is very important, because it explored this as not just an individual hospital, but as something adopted system-wide. And when they did that, they saw, a significant effect on preventing serious venous thromboembolism.
Yeah. Interesting. Could you comment a little bit? We always talk a lot about the DOACs and their safety and how great they are, but kind of what Warfarin's place is these days in VTE treatment and prevention, and patients on Warfarin who maybe aren't better off switching to DOACs, just something along those lines.
Yes, Warfarin still has a place. For most patients who develop venous thromboembolism, new, I think the direct oral anticoagulants will be preferred. But I think there are some groups where Warfarin is preferred. First of all, people who have been taking Warfarin for a long time, they are quite comfortable with it. They have a stable INR that's easy to regulate. They don't have problems with that bouncing around, and they're in the range at a very high proportion of the time, and it's not a burden to them. I wouldn't, mess with necessarily changing them over. So stable on Warfarin, not a burden to the patient, good proportion of time in therapeutic range. It's totally okay to continue on Warfarin. Warfarin will still play a very important role in a couple patient groups. If you have a mechanical heart valve, and say you develop venous thromboembolism or so on, you should be on Warfarin instead of a DOAC, because there are a couple studies which showed that that the direct oral anticoagulants seem to be less effective in heart valves, and one of those was just stopped this week, actually, in the case of these, transthoracic type valve replacements. So a heart valve, mechanical heart valve, not DOAC, stay on Warfarin. And also we learned from a study called TRAPS that people who have antiphospholipid antibody syndrome probably should not be on a direct oral anticoagulant, but should be on Warfarin. And those are, three key groups.
Great, thank you. And one final question. What is the number one thing that you want patients to do to help raise awareness about VTE?
We would like, if you're a patient, we would like them to, tell their story about how this happened to them. So, there'll be sort of two general categories of that. There'll be people who just spontaneously develop this, what we call unprovoked venous thromboembolism, but they didn't have any identifiable risk factors, so we weren't really able to prevent it, but they just suddenly developed the symptoms and came in. And tell your story about what your symptoms were like. What did you feel? What did you know? Tell it to everyone you can. Tell it to the doctors, because what it will emphasize is the wide variety of different ways that this can present, and it will help clue people in to not ignore things like minor chest pain or a change in breathing or their breathlessness, that there's, that's nothing, that I'm out of shape or something. Tell your story, especially if you have some, sort of unique type of presentation or so on, so that you make other people aware not to ignore these kind of chest symptoms or leg symptoms if you develop them. That's for the unprovoked VTE, and make people increase their alertness for investigating for this problem. And then if you've developed a thrombosis after a surgery or a hospital stay or something else, talk about that too, so that people are aware that if they go into hospital or if they're having surgery, they should ask for a VTE risk assessment. They should say, what is my risk of developing VTE? Should I get prevention? So those two would be the main things.
Great. And then join the Twitter chat tomorrow.
Absolutely. Yes. Thank you.
Yes. Awesome. Well, I know NATF will be a part of that, and we're really looking forward to it. Well, this has been terrific speaking with you. Thank you so much for taking the time, Gary Raskob and Barbara. We really appreciate it. Again, you guys do such great work. It's really amazing, and we look forward to continuing to celebrate World Thrombosis Day over the next couple of days, and spreading the word. So thank you so much.
Well, thank you, and just again, thank you to all of you at North American Thrombosis Forum, and especially to all those listening on the call for all they do every day to increase awareness about this. We really, really appreciate it, and you're doing great work and having a big impact, so please continue.
Great. Well, thank you so much. And thanks everyone for joining us tonight. A reminder, our next online support group will be November 5th at 7 p.m. Eastern Time. And we will be joined by Dr. Christian Ruff from Brigham and Women's Hospital, who will explore why patients get blood clots and genetics and blood clots, what's in the genes. So we hope that you'll be able to join us for that. Once again, thank you so much.
Thank you.
Yep. Take care. Bye-bye.